In this lecture, we will discuss accelerated junctional rhythm, including its mechanism, potential causes, EKG features, and basic junctional rhythm terminology. Accelerated junctional rhythm originates in the AV junction, which typically includes the AV node and the bundle of His. It occurs when the rate of the AV junctional pacemaker exceeds that of the sinus node, yet still remains within the normal limits of the sinus impulse. This may arise if there is an increase in automaticity in the AV node, a decrease in automaticity in the sinus node, and or sinus node dysfunction. You pretty much have the AV node outcompeting the sinus node, and as a result, it takes over the normal pacemaking function of the heart. Okay, so what we have here is, remember, this is our sinus node here. Okay, we'll use another color. So this is our sinus node. This is our AV node, our His bundle right next to it or underneath it. That's our AV junction. Okay, so what we have going on here is that we're saying that there could be some sinus node dysfunction or decrease in our sinus node automaticity, okay, meaning that it's not firing, it's firing at a slower rate. And we can also have an increase in AV nodal automaticity, okay. So if you have those coupled together, decrease in sinus nodes, so this is firing slowly, but this is also firing faster, okay, you can see how it could then go into the range. Remember, the normal intrinsic rate of the AV node is 40 to 60. So if you have an increase in AV nodal automaticity, it may exceed that 60 beats per minute, okay, and then fire between our normal sinus intrinsic rate, okay, between 60 and 100 beats per minute. And that's what we're going to see here. Now, the pacemaker cells of the AV node, or more precisely at the junction of the atrium in the AV node, are capable of depolarizing spontaneously and becoming the site of origin of the cardiac rhythm. Remember, the intrinsic rate of these junctional cells is normally between 40 and 60 beats per minute, okay? And this is below the normal intrinsic rate of the sinus node, which we said was between 60 and 100 beats per minute. And therefore, because the intrinsic rate of the sinus node is faster than that of the junctional cells, we typically consider the sinus node the normal physiologic pacemaker that sets the beat-to-beat pace of the heart. Now, if there is some sort of sinus node dysfunction, whereby the sinus node doesn't fire, the AV node may then take over in what we call this junctional rhythm. It is then from an increase in AV nodal automaticity, so this increase here of this AV node being cited even more, that we get this accelerated junctional rhythm manifesting. Okay, so again, we're saying that the rate of the sinus node is normally between 40 and 60 beats per minute. Now imagine that the sinus node is impaired, okay? And then you also have an increase in AV nodal automaticity. So this, which normally has a rate between 40 and 60, will be above that, okay? And may get into our range of 60 and 100 beats per minute, okay? And that's what we'll see here. Now, some potential causes of accelerated junctional rhythm include myocardial ischemia, myocarditis, cardiac surgery, as well as medications. The classic cause is digoxin toxicity, so make sure to look out for that. Beta agonists such as isoproterenol and epinephrine are also culprits. All right, now to the EKG features. In general, we define an accelerated junctional rhythm as a regular rhythm with a rate between 60 and 100 beats per minute, a normal and narrow QRS complex, and one with no relation to the QRS complex in any preceding atrial activity. So that's the basic overview. Now let's look at this in a little more detail so we understand why we see what we see on the EKG. So we said that this accelerated junctional rhythm arises from the AV node, and therefore activation below that region, that is activation of the ventricles, will typically be normal. In other words, there is normal antegrade conduction of the impulse down the normal electrical conduction system of the ventricles, and thus there's normal intraventricular conduction. As a result, we get QRS complexes that will be identical to the underlying rhythm, okay, and they'll be typically regular and narrow, okay. So just like all these other junctional rhythms that we've been discussing, remember, we're originating here and we're conducting down antegradally to our ventricles, but everything should be normal, so we see these narrow QRS complexes that are occurring throughout our rhythm here. Now there's also the retrograde conduction to depolarize the atria, and because both ventricular and atrial depolarization are happening nearly simultaneously, the QRS complex and P wave will often appear together. And depending whether the impulse origin is high, mid-level, or low in the AV node, we can see the P wave appearing at different areas relative to the QRS complex. For example, at times the P wave may be buried within that QRS complex. At other times you may see antegrade or retrograde P waves. Okay, the antegrade P wave is simply a P wave that appears before the QRS complex, whereas a retrograde P wave is one that appears after the QRS complex. Okay, so again, the same thing that we've been saying with all these junctional rhythms. Okay, everything is pretty much both atrial and ventricular depolarization occurring both at the same time. Okay, and because of that, we can have our complexes, if they occur at the same time, buried within, so our P wave buried within our QRS complex, as we see here, or we can have it occurring higher. Okay, in such cases, maybe the atria depolarized before the ventricles. All right, in such cases, we would see a P wave coming before our QRS complex, or we can have it low, okay, and such low in the AV node, maybe the ventricles depolarize before our atria, and in such cases, we may see the P wave coming after our QRS complex. Now, as previously mentioned, both atrial and ventricular depolarization occur nearly simultaneously, and because AV nodal conduction makes up the majority of the PR interval, we will end up having a very short PR interval, or at least one that is less than normal. And sometimes the PR interval may be absent. Okay, now that's because we could have the P wave actually occurring within our QRS complex, as we see here, and we won't have a PR interval. Okay, and this short PR interval is due to the fact that the impulse is originating from within the AV junction. Okay, so again, all we're looking at here is our origin of the impulse coming from here, because the PR interval, right, the PR interval represents from, here's our P wave, our QRS complex, and T wave. Our PR interval would be from the beginning of our P wave up until the beginning of our QRS complex. Okay, so you can see if our P wave is inside of our QRS complex, we won't have a PR interval. Okay, and also if it's occurring, right, if we have these occurring almost at the same time, we can imagine our P wave coming right here, so it would be very close. All right. So hopefully that's making sense by now. All right, so because atrial depolarization occurs in a retrograde fashion, we will see an abnormal P wave axis, okay, just like we saw in junctional rhythms. Instead of the mean electrical P wave axis heading leftward and inferiorly, giving us upright P waves in the inferior leads like we would see in sinus rhythm, we will instead have the P wave axis going in the opposite direction in the frontal plane. And this leads to inverted P waves in the inferior leads, 2, 3, and AVF, and upright P waves in lead AVR. That is, if we were able to even make out the P waves. Remember, they could be buried within our QRS complex. Okay, so we're saying here, remember our P wave axis between 0 and positive 75. So this is the normal P wave axis. As things come from our sinus node and head in this direction, imagine this arrow representing that. Now our leads, remember, lead 2 sits at positive 60 degrees. Lead 3 is here. This would be lead AVF. Okay, you can imagine lead 1 at 0 degrees. AVR would be at this place. Okay. And what we're saying here is now we have the origin starting here within our AV node, and conduction will be going pretty much in the opposite direction. So you can think of it going pretty much opposite of this. And in such cases, you see that arrow now going towards lead AVR, okay, our vector. So we'll see upright P waves in those leads, and it's going away from these leads. So we see inverted or negative P waves in those inferior leads, okay? Now this is a regular rhythm, and what differentiates it from other junctional rhythms is its rate. The rate of an accelerated junctional rhythm is between 60 and 100 beats per minute, okay? So again, let's look at this rate. So again, this is a regular rhythm. That's one thing to keep in mind. Regular rhythm, because our R to R intervals, right, throughout, all these R to R intervals will be constant. They're all the same length, okay? And then if we look at the rate here, because it's a regular rhythm, we can count the number of thick lines between each R wave, okay? So 1, 2, 3, 4 thick lines. So 300 over 4 gives us a rate of about 75 beats per minute, which is within that 60 to 100 beats per minute range, okay? So we're almost done here. Let's just review the basic junctional terminology, okay? So remember, the terminology is based on the rate of the rhythm. We'll go from the slower to the faster rates, okay? So first we have the junctional bradycardia, and this is defined as a junctional rhythm with a rate of less than 40 beats per minute, okay? In other words, we have a slower junctional rhythm. Then we have the junctional escape rhythm, which has a rate between 40 and 60 beats per minute, and this is the normal intrinsic rate of the AV node. Then we have the accelerated junctional rhythm, as we're looking at here. This one has the rate between 60 and 100 beats per minute, but still it's less than 100 beats per minute. And then we have junctional tachycardia. Just like the other tachycardias, it has a junctional rhythm, okay, that now exceeds 100 beats per minute. And one final point that we'll make is the classification that you may hear based on etiology of these junctional rhythms. This means that they may be due to enhanced automaticity in the AV nodal cells, and this is known as an automatic junctional rhythm. And then there are those junctional rhythms due to reentrant loop involving the AV node, which we call reentrant junctional rhythms. An example of this would be an AV nodal reentrant tachycardia, and this is something we'll discuss in future lectures. All right, so hopefully this is all starting to come together. You're probably a pro with these junctional rhythms by now. Let's briefly run through our chart before we end here. So again, these accelerated junctional rhythms result from rapid impulses, okay, originating within that AV junction. The rate in that is greater than that in the sinus node, okay? We're still going to have the anterograde conduction to the ventricles and retrograde conduction to the atria. The mechanism may be due to a result of a decrease in SA nodal or sinus nodal automaticity or sinus dysfunction where the sinus node isn't working, as well as coupled with an increase in AV nodal automaticity, okay? The AV node firing a little faster than it should. Some causes we mentioned here: ischemia, myocarditis, surgery, medications, and so forth, okay? Now we talked about the junctional rhythm terminology, all based on heart rate, okay? And we talked about this one, the rate was between 60 and 100 beats per minute, okay? In terms of the rhythm, it was regular. We talked about the rate. The P wave may be absent if it's buried within our QRS complex. It may be coming before or even after, depending on if the atria or ventricles become depolarized earlier or later. Remember, the axis of the P wave will be abnormal, okay, as we're heading from the other direction. We have retrograde atrial conduction going on here. The P to QRS ratio, we may either have no P wave, okay, because it's buried within our QRS. In such cases, we won't have a ratio, okay, or it will be 1-to-1 if there's antegrade or retrograde P wave present. The PR interval, again, if our QRS complex is within here, we won't have a PR interval, or it will be short or retrograde, okay. And the one thing to note is that because we have this retrograde conduction, we do not have the atria depolarizing the ventricles as we would in a sinus rhythm. Instead, we have it coming from here and going retrogradely to depolarize the atria, okay? The QRS interval will be normal, okay? We have a normal width of our QRS interval, no issues there, okay? There will be no grouping and there will be no drop beats. Well, that's the end of this lecture. We discussed accelerated junctional rhythm, including its mechanism, potential causes, EKG features, and basic junctional rhythm terminology. I hope you learned something.